Hello, welcome everyone. I'm Philip Chang, and I am the president of the Sleep Research Society Foundation. I'm very excited to be here to welcome you and to thank you for joining today's SRSF Industry Scientific Seminar webinar on the topic of real-world outcomes with Nidra TOMAC for refractory RLS, integrating Thrive registry data with prescriber perspectives. Attendees will learn the science behind a sleep product and how it works directly from industry scientists with an opportunity for a question and answer. Please note that the SRS and the SRSF do not endorse any products discussed on these webinars. So with that, let us explore how our shared mission of growing knowledge can help further the field. Without further ado, I would like to introduce Dr. Jonathan Charlesworth with Noctrix Health.
Well, thank you very much for the introduction, Dr. Chang, and thank you to the Sleep Research Society for this opportunity today. As Dr. Chang mentioned, I'm the industry scientist, PhD neuroscientist by training, and I'm actually the co-founder of Noctrix Health, the company that invented the Nidra TOMAC technology, and currently serving as the chief scientific officer, leading research and leading medical affairs as well. Our mission at Noctrix Health has been to develop low-risk therapeutic solutions to address the unmet need in restless leg syndrome. And Dr. Spector today will share in depth his experience with that unmet need. As we've grown from a team of two to over 100 people today with offices in Silicon Valley and Pittsburgh, Pennsylvania, our North Star at Noctrix Health has remained the same, helping RLS patients control their symptoms, restore their sleep, and truly reclaim their lives as well. Of course, I'm joined today by Dr. Spector, and he's a board certified in sleep medicine and neurology. And he'll be here today to share his perspective as a prescriber. Dr. Spector is a professor of neurology at the Duke University School of Medicine and currently serving as program director of the Sleep Medicine Fellowship there. Through his active clinical practice, he manages a large population of RLS patients who are refractory to medication. And so he has direct experience not only managing this condition, but also with the technology, the Nidra TOMAC that we'll be talking about today. Dr. Spector is also the author of a bestseller book for RLS patients called Navigating Life with RLS. Before we dive in, I do have to cover our disclosures. Of course, I'm a full-time employee of Noctrix Health. I am the industry scientist. Dr. Spector is mostly independent, but he is paid for his time as a speaker by Noctrix Health. And with that, I'll turn it over to Dr. Spector to share his clinical experience with this condition.
Thank you, Jonathan. Good to be with you. And thank you for the opportunity to talk today to the SRS who has sponsored this, and we appreciate it. I also add the caveat in the disclosures that I'm not speaking on behalf of Duke in these comments. This is really just my opinion and my experience that I'm talking about today. And I'm going to start by talking about restless leg syndrome as a condition, and one that is, I think, from my experience, thoroughly underrecognized for the severity of distress that it causes to patients. And I think you're here to learn about RLS, so that means you must have experience treating these patients and seeing what I've seen, which is that they are suffering greatly. And it disrupts their lives, it disrupts their quality of life, disrupts their sleep, and we're learning more and more about the health burden that's associated with restless legs and the disruption of sleep that comes with it and the long-term health consequences of this condition. So it's dangerous for them to live with this, and it causes a huge degree of distress. And I think it's underrepresented in the medical community, even though we know that anywhere from maybe 7 to 10% of American adults are living with this condition. It certainly doesn't represent that amount of medical training or experience with the primary care world or even general neurology, where a lot of this is being taken care of. So I think we need to do better for our patients, and I'm always on the lookout for ways that we can be doing better to take care of this really, really problematic condition. And for decades, we've been using a variety of different drugs to do that, but they all have problems associated with them. In the past, benzodiazepines were common. This was decades ago. And then along come the dopamine agonists. And these really got popularized in the 90s and early 2000s. Um, but the more we've used these drugs, the more we realize there are major problems. And it's why the 2024 AASM guidelines have taken out dopamine agonists as the primary therapy because augmentation and impulse control disorders were major problems with the dopamine agonists. And so that became a serious limitation because for all their problems, they did work, right? We know they work, especially at the beginning. So when we take out the dopamine agonist, and then we're looking at things like gabapentin and gabapentinoids, well, not everybody tolerates those very well. They give you that drugged up feeling, and there's a high rate of psychiatric illness associated with gabapentinoids, weight gain, and significant limits. As safe as they are in theory, they're not always well tolerated. And once you get past the gabapentinoids, you're looking at drugs like dipyridamole, which can work in a subset of patients, or opioids, and those have a ton of limits, right? Opioids are extraordinarily valuable for restless legs, but even when they're working, they're a pain to get. Every day I'm fighting with pharmacies, please give the patient their drugs, trying to get the insurance companies to cover opioids for restless legs is a burden, and then they're dealing with stigma. So we were living in this milieu where all we really had were drugs, and the drugs were all problematic. And then we add to that there are a lot of providers out there who really aren't educated on restless leg syndrome, how to treat it, when to utilize iron therapy, which I'm a big proponent of, and how to incorporate that. And they're still prescribing dopamine agonists, even a couple of years after the guidelines came out saying we've got to stop that. So there are a lot of big deficits in the restless legs community. That's why I feel passionate about treating this population. I think there's a lot of room for us to be doing better.
Well, thank you so much for sharing your experience. And this is truly what motivates myself and everyone at Noctris Health to go into the office every day. We interact directly with these patients and hear their stories of their suffering and the limitations of the current options. Before I dive into the technology and the clinical data, one housekeeping item: if you do have any questions, please drop them in the Q&A chat, and we'll address them maybe during the presentation if we notice them, but definitely at the end. So, how did we come to develop a therapeutic for RLS? It really came from a clinical insight, one of the core diagnostic criteria for this condition. And I really learned about this first from Mark Bacure at Stanford University, and I really understood this condition from hearing about his experience and his understanding of it. And what I learned was something you all probably know by now, but this was about 10 years ago, we're talking, which is that if somebody's lying in bed and their RLS symptoms start, if they get out of bed and they walk around, they get some temporary relief. And unfortunately, it doesn't typically help them fall asleep because it's very short-lived relief, but it does provide some relief from that discomfort, from that urge to move. What I learned is, as I learned about this condition more, is that it's not just walking. It's really any voluntary activation of the leg muscles. If you stretch, if you get on a stationary bike, any activation of this neuromuscular circuitry leads to relief. And as we dove into this more, we realized, hey, you know, with a neuromodulation technology, we should be able to activate these same neuromuscular circuits. Is there any way to do that while being compatible with sleep? So that's eventually what led us to the technology we have today. And briefly, the way it works is that it taps into the same neuromuscular circuitry that's activated while walking, but it does so at a level that is comfortable and compatible with sleep, meaning that instead of getting out of bed and walking around, a patient can lie in bed, turn this technology on, get relief of their symptoms, and fall asleep while it's running. It also uses an extremely high frequency of neurostimulation. It uses 4,000 pulses per second. And why is that important? Well, if you think about other forms of neurostimulation you may be familiar with, you probably think about implants, like spinal cord stimulators, deep brain stimulators, and this is my background, and these are extremely powerful. Unfortunately, they require a surgical implant. Um, Dr. Spector mentioned there's millions of Americans with RLS. There's, by our estimates, 2 million Americans that are actually refractory. And there's no way you're going to be able to serve that large of a patient population with an implant. So we need something that can actually be readily available without surgery, that can be prescribed earlier in the continuum of care. And in order to develop that, what we needed to develop was a way to send powerful nerve stimulation across the skin. So instead of needing a surgical implant, you can use a wearable technology. And this is actually what the device looks like today. There's no invasive procedure needed. It's actually just worn on your legs. And that high frequency stimulation essentially short circuits the skin. The skin resists the flow of electrical current, but high frequency short circuits a capacitor. It allows you to get highly powerful neurostimulation to the nerve, to the circuitry that provides relief. And so that's tonic motor activation. And all that means is motor activation of this circuitry in your nervous system that is not phasic, like walking, but tonic. And that's important so that it can be compatible with sleep. A phasic signal that would jerk your legs would keep you awake. A tonic signal, you can kind of think of it like white noise for your nervous system. It calms things down without alerting you. So what is Nidra? Nidra is just the brand name for our device. It's the only device out there that delivers this mechanism of action. It's the only device out there that delivers high frequency peroneal nerve stimulation, which is how this is referred to in the AASM guidelines that Dr. Spector mentioned. Many of you are probably familiar with the technology by now, but briefly, it involves these two wearable, external, rechargeable neurostimulation devices. These are worn just below the knee. And the reason for that is, we're trying to activate this circuitry of the legs. Walking activates the motor circuits of the legs. We're trying to activate those same systems. What's the most easily accessible nerve for non-invasive neurostimulation? It's the nerve in the legs that's closest to the skin surface. And that ends up being the peroneal nerve just below the knee. And so that's why it's placed at that position. And the positioning is very important. And it does need to be within about a half an inch of the head of the fibula, just below your knee, to produce a reliable, high potency activation of those circuits. The interesting thing, one of the interesting instructions for use of this that's a contrast to most of the medications for RLS is that it's activated as needed. And the reason for that is the onset of relief with the Nidra device is very fast compared to the medications that are available for RLS. Most patients do report relief in about 10, 20 minutes, 30 minutes at most. The device does stimulate for 30 minutes, it shuts off, and then patients typically report a couple hours of relief afterwards. So that relief is long enough. Even patients have some sleep onset insomnia. That relief is long enough for the patients to get into restorative sleep. I'll be talking today primarily about the new data, the hot off the press data from the Thrive real world registry. But for those who are interested in learning more, there are 9 peer-reviewed publications already out there from 5 previous clinical trials. And the results of those show very similar things to what we're seeing in the real world today in terms of high potency benefits around the level that you see with the strongest medications and extremely favorable risk profile, which is what you'd expect from a wearable non-invasive device, but still very important to prove that out and have proven that out through these randomized clinical trials. These data were reviewed by the FDA, they were reviewed by Medicare, they're reviewed by the authors of the AASM guidelines, and all 3 of those groups had a very favorable impression of the data. So this led to the FDA de novo authorization. For those who aren't familiar with the de novo, it's very similar to 510K. It means it's a class 2 medical device. The difference between this and a 510K is the first one of its kind. There's nothing like this out there. There's no existing predicate. So you actually have the FDA review your clinical evidence and create a new category, which is what they did here. Um, and it was recommended, as Dr. Spector mentioned, dopamine agonists are no longer recommended in the 2024-2025 ASM clinical practice guidelines. Nidra is, and it's referred to as the high frequency peroneal nerve stimulation that I mentioned earlier. And I think most importantly, when you look at medical devices, especially non-invasive medical devices, you see a large number that have 510(k), that have FDA authorization, FDA clearance, but many of them are not covered by insurance. And so it's great that the device is out there, but can a patient access it? That may be challenging. So I think one of the things we're most proud of at Noctrix is that Nidra is covered by Medicare. It's also available at the VA medical centers as well. And we're starting to see traction with commercial payers too. Importantly, the FDA labeling, which is based on our pivotal trial, is indicated for adults who have moderate to severe RLS and are refractory to medication. And I think one of the questions I get most often is, hey, what does refractory mean? And if you're coming from a world of treatment-resistant depression, or you're coming from a world of implanted neurostimulation, you have to fail a lot of things to be called refractory. It's important to draw a contrast to that and this definition of refractory. This definition of refractory is really broad. It's inadequate response to one medication. And so that could mean early stage augmentation, late stage augmentation could mean that the patient went on gabapentin for a few months and couldn't tolerate a high enough dose to be effective. In fact, many of the patients we see that get prescribed Nidra today are currently on a medication, but it's just not providing enough relief. It's providing an inadequate response. So what we see is this definition is covering about 2 million Americans. So it's a pretty broad category. The one thing to note in the contraindications that comes up most regularly is that active medical device implants are contraindicated. So this includes pacemakers, the Inspire medical device for sleep apnea, and less common stimulators like spinal cord or deep brain stimulators. So I'll kick it back over to Dr. Spector before we get into the data, to give him a chance to share his experience, how he found about Nidra, what his experience has been so far.
And so I remember in medical school they hammered it home that doctors should not be early adopters, right? That might be fine when you're buying an iPhone, but not for new things on the market medically. You want people to have experience. You don't want to be the first one to prescribe anything. And admittedly, I kind of threw that advice out the window with Nidra, and I was hoping to be the first one on the block to prescribe it, because I was looking at the data coming out about the device. I looked at the safety data, I looked at the efficacy data, and I looked at my patients who were very much in need of something else, some other option. As Jonathan said at the beginning, I have a lot of refractory patients in my practice. A lot of them are coming to me with augmentation and had been on every drug and, really everything, the opioids, and they were still having breakthrough symptoms. And so I reached out to Noctrix. I said, you're FDA cleared. Can I get the device? They said, well, we're not in North Carolina yet, but stay tuned. So essentially, the first day, I took this list of patients I had been collecting for basically several months after they got approval before they got to North Carolina. And as soon as I got the word that they were now ready to go, I had a list of patients, started prescribing it. Now that list were some of my most difficult patients, the ones that I really was out of options with. And now realistically, that may not be the best starting population because they failed everything else. Having them test this new thing and then deciding whether it was working based on patients who already didn't tolerate or do well with every other option may not have been my best window into the efficacy, but it kind of proves the point that even they were benefiting. And when they came back, and I'm not making this up, they really did say things like, "This is a miracle." Their words, not mine. And they were so excited. I got an email from a patient. Thank you for considering me for this therapy. Like, well, I had no other options, so I did consider it. But that's the kind of level that I was taking my most severe patients, getting them onto Nidra as fast as I could, because that's who was really looking to try something new. And they were giving me positive feedback. So at that point, I'm like, well, if it's working for you folks, I really kind of lowered my bar to be prescribing it with others, because if it can work with them, it could work with anyone. So then it started to grow from there. I've prescribed it well over 100 times at this point. And yeah, it's just about getting it approved, and getting the insurance coverage, because it was working so well with the most difficult patients that I don't have a limit anymore. And we're going to get to some of that in a little bit as to who I'm targeting for this device.
Well, thank you so much for sharing your journey. And with no further ado, I'll turn the attention to the main focus of today, which is the new data from the Thrive registry, which is hot off the press. And this is it's a very important study, and it's a very important study for two reasons. First, as Dr. Spector mentioned earlier, if you looked at just the response in a 12-week clinical trial with dopamine agonists, you'd think these are miracle treatments. But when you look longer term, you realize that with the dopamine agonists, they lead to augmentation. So we wanted to be very careful here and understand, we have the RCTs on Nidra. We have the 4-week studies, the 8-week studies. The results look very good there. But what happens if you follow a patient over a year? Do you still see that sustained response? So that was one motivation, durability of effectiveness and safety as well. And then the second was, the real world population, as Dr. Spector mentioned, and he's not the only one, prescribing for some pretty complicated patients. Do we still see the type of benefit you see in a randomized controlled trial where you have a list of inclusion and exclusion criteria that you worked with the FDA on? Now you don't. Now you have the complicated patients that are struggling with comorbidities, that are struggling with mood disorders. Are they still going to see the same benefits? So those are the two motivations for doing this study. And data I'll be presenting today, because I do think the 1 year data are the most important. I will be sharing the interim data at 1 year. So we're enrolling 325 total patients. There aren't quite that many in this data set. But I think the 1 year data are the most important from this study. And so out of the 325 total that we're enrolling, we have a data set of 234 that we pulled about a month ago to do this analysis. And the data I'll be sharing today are for all patients who meet that FDA label. And we do get some patients off label that make it through insurance coverage today. There's some that are not refractory, some with mild RLS, and some that are contraindicated, but we're not analyzing those here. It's important to note we are using intent to treat analysis. So if a patient drops out over the course of the trial, we still impute their data forward and include them in the analysis set. Importantly, there were 47 dropouts from the study, and about 40% of those returned the device. So for patients that are cash pay or commercial, we have a return policy, 45-day return policy. If they're not getting relief, they can return it. So that's why we typically see about 9% return rate there. But many of the patients who dropped out, is just we're requiring them to fill out a questionnaire every 2 weeks, and they no longer have time to do that. But either way, we're taking their data, imputing it forward. It is intent to treat analysis. So I think one of the first things that I was really interested in with this study is understanding, like, who are these patients? Like, we knew who the patients were in the trial because we made those inclusion and exclusion criteria. Who are they in the real world? Do they look similar? Do they look different? And in many ways, they actually do look similar. But there are some key differences. Starting with the similarities, as expected, a lot of these patients are still on medication. About 90% are still on medication. And despite that, they have severe RLS symptoms. So the average starting IRLS score is 25, which is right in the middle of that severe range. 20 to 30 is the severe range. This is something we've seen consistently across every trial. I'm sure Dr. Spector's seen in his clinical practice. This is mostly due to augmentation. They have a hard time getting off these medications. They're not providing adequate relief, but they can't stop them either. And so what we see here in terms of a mix of medication, a lot of patients are on the dopamine agonist, 60%. But I actually think that's lower than what you'd see across the trials we had. And I think part of the reason of this is early adopter prescribers of Nidra have tended to be the type of prescriber who tries to get their patients off dopamine agonists. So here you see also a lot of patients who are on alpha to delta ligands. Typically, the reason for that is they are getting some relief, but just not enough relief because they can't tolerate a high enough dose of pregabalin or gabapentin to truly get control over their symptoms. And the other thing that really struck me here is that the rates, if you look at the very bottom here, the rates of mood disorder and mental health comorbidities, insomnia is not surprising for that to be so high. But for clinical depression and anxiety, the RLS that these patients are having are leading to a much higher rate of these mood disorders as well and impacting their quality of life. So wanted to just kick it back over to Dr. Spector. This is kind of what the overall patient population looks like, and I know you touched on this a little bit already in terms of kind of who you prescribe it to, but any other thoughts or experience there?
Yeah, so now it's a different answer than when I started, right? At this point, I'm prescribing Nidra very early. And part of that is because generally the patients I'm seeing are not early in their RLS care. They've already seen other providers, they're already on various treatments. I don't tend to see a lot of people walking in the street saying, I get some strange feelings in my legs. What might that be? Or I'm the one making the diagnosis. So I've got a population of patients, some of whom have been treated for decades with various drugs. And really, it's part of my first visit now. So, my general practice is going to be starting with, any triggers I can get rid of, the caffeine and antihistamines and all the triggers. We move on to iron, make sure that I've given them iron, often iron infusions, because I prescribe a lot of iron infusions. And in that same visit, I'm going to talk about the option for Nidra assuming there are none of the contraindications like implanted devices, which doesn't really affect that many of my patients. So for the majority of them, as I'm having that very first conversation, I'm introducing it right away, partly because as I'm about to start treating their augmentation and taking away their dopamine agonists, we all know that that's going to be a miserable process, and they feel horrible when you're coming off the dopamine agonist, no matter what we do. But if they can have an option like Nidra on hand as we're doing that, I can cushion some of the withdrawal symptoms. They have a go-to option that isn't just more opioids or something like that. So I want the bands in their hands or on their legs as I'm doing the wean off the dopamine agonist because I think it goes a little better when they have that option. So for those patients, and then the other subset of patients I'm getting are those who are transferring in. Maybe they've already been well treated, and they've moved to my area. They're on opioids already, but they say, I'm 80 to 90% better on my current therapy, but I get breakthrough symptoms. There are just some nights, maybe I exerted myself and walked extra during the day, where their current medical therapy is not 100% covering them, but they don't really want to go up on the dose. And I don't need more every day. I don't want to be on a higher dose of opioids all the time. This is another great population that I'm looking for because they have something they can turn to without needing more drug. So they're mostly well controlled, but need a little something extra. And so those are the two primary populations that I think I'm seeing the most of, where I think Nidra is a great addition to their care.
Well, thank you so much for sharing that experience. And I think we see something similar where, the initially when a prescriber considers Nidra in their continuum of care, it's the worst of the worst. It's the ones they haven't been able to solve for 10 years. And then once they have positive experience, you see that branching out to other patients under that refractory umbrella. So moving on into how's it working? It's taken us about a half hour to get here. I'm sure this is what everybody wants to see. We're looking at the RLS score here. And this goes from, 0, no RLS, all the way up to 40, which is the most severe possible. And, as I mentioned, with pretty much any clinical trial, when you have a cutoff of moderate to severe, you end up with about 25 to start with, right in the middle of that severe range. It's what we saw in our RESTful pivotal trial. It's what we see here too. And in that first 90 days, we see more than an 8-point reduction in the RLS score. And that was very similar actually to what we saw in the pivotal trial. I think we saw 8.7 point reduction in the RESTful trial compared to 8.1 here over that first period. And so that's remarkable. That was really surprising to me. I'm the clinical researcher. I put together all these inclusion exclusion criteria that I thought were important. Turns out they weren't that important. Well, they're important to the FDA, but they don't actually affect the effectiveness. It turns out even in this broader, uncontrolled real world population, Nidra is doing just as well as what you saw in those clinical trials that are published in Sleep a couple years ago. So that was really exciting. And then the second exciting thing to us was that as you look at day 180, day 270, day 365, that benefit continues, and there's no downside over time. So this was really important. RLS is a chronic health condition. It's affecting patients for the rest of their lives. They're going to need to be on treatment for the rest of their lives. And this appears to be that long-term solution that's going to continue to benefit patients. If you look over on the left in that histogram, the mean change in a scale like this doesn't tell the full story. You need to really understand, what's the distribution there. But for this therapy, it actually does seem that kind of the mean, the median, the mode, it's all about this 10-point reduction. What does that mean? So I want to share some slides, but also share some feedback from patients. Like what is a 10-point reduction? Going from 25 down to 15. A patient that's at 15, what do they tell you? So first I'll share some data and then I'll share kind of some patient experience with that. So to dig into this, I mentioned that biweekly, some of the patients drop out because we're sending a biweekly questionnaire. This is that biweekly questionnaire, and these are the results from that. And what we ask patients on the biweekly questionnaire is two questions. One is when you turn Nidra on, you have symptoms, you turn it on, do you get relief? Is it a reliable painkiller? That's the first question. That's the acute relief question. And then the second question we ask is very similar to the RLS. Overall, how has your condition improved? How has your RLS severity changed? And we see two different timescales of relief here, which is kind of interesting, a little bit of a dichotomy. The acute relief happens pretty quickly. It plateaus pretty quickly. It stays stable. But within that first 2 to 4 weeks, as soon as a patient knows where to put it on their leg, over the head of the fibula where the peroneal nerve is, knows how to dial up the intensity to the range where it's actually activating that nerve and activating that neuromuscular circuitry, if they're ever going to get acute relief, they will achieve it by then. And so we see about 80% of patients do get that acute relief. And I'll talk in a couple of slides of the other 20, what's going on. But that effect happens quickly. It's very consistent over time. But the reduction in RLS severity takes a little longer to truly plateau. So you start getting some hints of it in that first 2 to 4 weeks. But looking out to 10 weeks, that's really where you start to see most of that benefit. And then you actually see a trend towards improvement from week 10 to week 20, even from week 20 to week 30. So what's going on there? I think part of it is just you're getting better sleep, and you continue to get better sleep, your RLS reduces. But there's another effect we see. And this is something that we saw in an extension study a couple years ago that's published in Sleep, where we followed patients out to about 24 weeks, about 6 months. We see it again here. And this is something that has been seen with other forms of neurostimulation. And what it is a reduction. It's basically an increase in symptom-free days is a way to think about it. And there's neurostimulation treatments that have seen this for migraine, I think epilepsy as well. And what we see here for RLS is that when patients get their Nidra bands, really most of them have symptoms 7 days a week. On average, it's 6.1. It's almost every day. And for many of these patients, it's been every day for 10 or 20 years. Um, and over time, that frequency of symptoms decreases. And the important thing to remember here is this is a as needed treatment. So if a patient has a symptom-free day, it's not because they used the bands before their symptoms started and they didn't get symptoms. It's that they didn't get symptoms that day at all, and they didn't even need to use the bands on that day. So there's some carryover effect, likely some neuroplasticity going on. This is an interesting one. I just putting on my industry scientist hat. Yeah, hopefully next year, he can come back and have one of these, and I can tell you what's going on in terms of the nervous system that's leading to this effect. We don't know yet, but we are studying that. We are interested in understanding that. One thing to keep in mind, this effect is extremely meaningful to patients. It doesn't happen for everyone. And if you look at the histogram on the left here, you see that it looks a little different than the last histogram. This isn't a bell curve. There's a lot of patients who have this benefit. There's some that don't. And the ones that don't really like Nidra. They still get relief. It still gives them the painkiller effect, but they don't all get this. So that's another thing we need to understand, who experiences this benefit and who doesn't and why. So a lot of things that we're exploring as a company, exploring as a research team, as a department, to understand better the mechanism of action of this specific effect. We understand very well the mechanism of action of the immediate painkiller acute relief effect, but not so much this long-term effect. As expected, relieving RLS symptoms, having after effects that last for a couple hours, we're continuing to see very strong improvements in sleep. And we use the MOS scale. This is a subjective compilation of 9 different items. But if you actually dig into item by item, what are the patients actually saying are improving about their sleep? And the items that really jump out are they're falling asleep faster, their sleep is more restful. But also, we see time and time again the patients saying that during the daytime, I feel better. I am more well rested. I am less sleepy. I am less drowsy. And that's, the sleep quality is important for health comorbidities, but daytime functioning, daytime sleepiness is critical for quality of life. It allows these patients to do things in their daily lives that they could not do before. So when you're thinking back to, what's that 10-point improvement mean? One of the impactful things is it actually means that, hey, I actually feel better during the day and I can do things that I wasn't doing before. And we see similar improvements on the Epworth sleepiness scale too, if you're more familiar with that than the MOS. In addition to that, I mentioned the fairly high baseline rates of these mental health and mood disorder comorbidities earlier on. And of course, as you'd expect from a big improvement in the MOS scale of sleep, the Epworth, we also see a big reduction in the percentage of patients who have clinically significant insomnia, as indicated by an ISI score of 15 or greater. That reduces from 52% to 30%. We also see improvement on the PHQ-8 and the GAD-7 metrics of clinically significant depression and anxiety, respectively. And all of these are statistically significant. If you dig a little deeper, again, into the items on these different scales, there's a few that pop out that I think match some of the patient testimonials we've heard. And one of those is that at baseline, before Nidra, refractory patients are extremely anxious about their RLS symptoms. And part of the reason for that is the unpredictability of those symptoms. A lot of the patients feel trapped in a particular pattern of activities in their daily life where they've realized that, hey, if I do exactly this on a given day, the meds that I'm taking, my symptoms will be manageable. But if I ever do anything different, if I go to a concert, if I get on a plane, if I get in a bus, I get in a car, I go out to dinner, anything different, even if I exercise more, I exercise less, I might have an episode that's so severe. And by the time it gets that severe, the medications take too long to kick in. I'm going to be up all night. So you get this anxiety around, I can't get outside of this box and do these things in my daily life because if the symptoms start, I have no way to rapidly deal with them. Nidra with the acute on-demand relief provides that rescue effect that can release patients from that trap. And we've heard this time and time again. Basically, everything I mentioned that keeps some of these patients trapped, they're able to do those things. They're able to get on the plane and see relatives they haven't seen in 10 years. They're able to go out to dinner. They're able to go to a concert, go to a movie, do exercise that they were scared of doing. So I think that's one of the things you're seeing here in terms of the anxiety, the depression, um, that direct effect that really comes through in the testimonials. So I kick it back to Dr. Spector and kind of what have you seen in terms of the benefits with your patients?
Yeah, I'm going to echo what you just said because that is the really big impactful benefit is that they have a rescue option. And one of my very first patients who I prescribed this to, he uses it to fall back asleep. That's his time of night. He wakes up in the middle of the night. He said, I used to pace for 2 hours in the middle of the night and I would get no sleep. Even if he would take rescue medication, there's such a delay before he would get the benefit that he was still up pacing around the house. And his big thing is that now he puts on the bands and he says he's back asleep within 10 to 15 minutes. And to him, that is such a huge win, right? That he's not up for hours upon hours in the middle of the night. So that's a big sense is that rescue backup plan that when they wake up in the middle of the night, they have something to do that works quickly. So I think you're right. This is a big quality of life problem. And when I told a patient the other day, she said, I've never been to Europe because I'm scared to get on a plane for that long. And I say, all right, by next summer, plan it. We'll get you to Europe for the first time because I'm confident that, she'll have this as a backup plan. She can take it on the plane with her, and she'll be able to make it through. So I think the quality of life is the benefit, that it really does enhance their confidence and their ability to treat their symptoms, and the lower anxiety has sort of a virtuous cycle effect. The less they worry about it, the less it's a problem. And I set expectations. First of all, when I talk about this, I say, be patient. This is not Amazon. You're not getting it tomorrow. So the expectation is it will go through a process. You'll go through the approval. It'll be shipped to you. It'll be titrated. So I said, this is not a tomorrow fix, but it will be a future fix once we can get it. So first, I explained the reality of what it takes to actually get the bands because it's not Amazon shipping. And then we talk about the titration process. So you have to find the right intensity for you, right? So I tell them if it's not right the first time, it can be reset. You don't necessarily get it perfect the first time you try to titrate, but realistically, more often than not, they do. There aren't that many patients who need to be retitrated, but I say it's okay. If you need it, that's fine. And then you get to experiment with the different levels, see what works for you. Um, a lot of them say, will I be able to stop my drugs if I do this? And I tell them that would be great, but I don't want you to plan on that. That's not really my goal here, is to get you entirely off your drugs. Off your dopamine agonists, yes, but not off all pharmacological options because most of them still need some extra drug support, but we may be able to lower your dose. You may be able to avoid taking PRN doses on top of your baseline doses. Those are reasonable expectations. And I also tell them that if they have both sensory and motor components to their restless legs, if what they're having is predominantly sensory, that I expect that will go away very well. If they have some associated myoclonus, I'm more ambivalent on that. I've seen it work for the myoclonic component of it, so some patients will have that, but I tell them I'm more interested in getting that unpleasant sensation to go away. I've seen it work better on that particular symptom. And anything else they get out of it, if it does calm their myoclonus, which can happen, then that's great also. So I try to prepare them for the experience with all of that. And also tell them to make sure they're changing their pads according to the rules. And then make sure that the gel doesn't dry out. That's the key thing to make sure that it's safe for them. And then success. Success takes a lot of forms. It really does. I'm not a scale person. I don't do Epworths in the clinic. I don't do IRLS scales in the clinic. I really don't. I mean, if you tell me you like it, that's success, right? You tell me that you feel better. I'm much more qualitative than quantitative in this world. So there are a variety of different ways I would accept that the bands were successful. Number one, did you keep it and not return it? I have people who put it on once, yeah, this isn't for me, they send it back. Okay, that's not success. But did you keep it and are you still using it? Because if you're still using it, you're getting something out of it. Otherwise, you wouldn't keep bothering to put it on. So just the fact that they're continuing to use it, I consider to be a success. I consider it success if you tell me that you're sleeping better, that you're falling asleep faster, that you're falling back asleep faster if you've woken up in the middle of the night. Um, I had one patient who came in and said, I don't think it's helping me, but I use it whenever I wake up in the middle of the night. I said, well, last time you told me that you were up for 3 hours in the middle of the night. Today you're telling me it's 20 minutes. She said, oh, well, that's true. I guess it is working. So sometimes we have to help the patients define success because when I pointed out to her what she said last time, she hadn't even realized how beneficial it had been. But then she was very much on board with continuing when we realized that, just my notes were enough to convince her that this was success. So those are the different ways that I would consider it to be successful. And like I said, really to me, it's about do they want to keep using it or not? And I've looked at my data. Right now, it's about 80%. So I told you I've prescribed it 100 times. Not all 100 of them have gotten the device because of insurance issues, but the percentage that got it, 80%, have kept it and are still using it. So to me, that's a really high success rate for anything.
Thank you so much. You mentioned you're replacing the CDIs regularly for safety, and that is very important. I think one of the things that we wanted to make sure of when we did this Thrive study was following patients over a year. Let's make sure there aren't any adverse events that we didn't know about, that there aren't any adverse events that we did not see in the previous trials. And the good news is that there's no neurology adverse events that are popping up here. There's nothing concerning about stimulating the nerve for a year. Really, the only thing we see that's a common adverse event is skin irritation at the site that you're putting the sticky electrode and you're sending electrical current across. The good news is no one discontinued from this study due to that. So when patients evaluate that risk against the benefit they're getting, all of them decided the benefit's more important. I'm going to stay in this trial. The other good news here is that the vast majority of these are mild. Um, and typically with training, with replacing the CDIs, this risk gets decreased as well. But comparing this to the leading drugs that lead to augmentation, that lead to risk of neurological side effects, this is the type of extremely favorable safety and tolerability profile that you'd expect from a wearable neurostimulation device. And most importantly, no serious, no severe device-related adverse effects, even at the 1 year time point with over 200 patients. So one of the things that Dr. Spector just mentioned too that I think is we'd hope to learn about through this trial was hey, out of the 100 patients, 80% are really happy with this. 10% return it, and another 10% kind of like, yeah, I get a little bit of benefit, but it's not what I was really expecting. So what's going on with that other 20%? If you look back to the acute relief, there's other 20% or the 20% that aren't getting that acute relief. What's going on? And as we've dug into this, the main factor that explains about half of it is proper use. And so at Noctrix Health, we have about a dozen team members who are spending 100% of their time coaching patients on re-education. So all patients get titrated, all patients get educated at day zero. But during that first month, many patients, more than half, need re-education on positioning the device over the nerve target or stimulating at a sufficient intensity to activate that nerve. Um, and we see a big improvement over that first month in the acute relief. But there are 10% of patients who just can never get the hang of it. And that explains about half of the non-responders. And this continues to be a priority for us. We're always looking at better ways to provide that relief, meet patients where they are. Can we get a patient on a video call so we can really look at that positioning? We now can do that. We have the technology for that. Can we have an app where a patient, if they need to be retitrated, reprogrammed, that can happen in their home. It can happen immediately, like on the call therapy support. We now have that. That's available. So these are just reducing barriers to re-educating patients, making sure they are using it in the way that's going to provide the most possible relief. I draw an analogy with CPAP here because most of the response to CPAP is explained by differentiation usage. But there's a big difference here. With CPAP, 60% of patients are adherent. With Nidra, about 90% end up being adherent after they go through this therapy support process. And I think the reason for that better adherence with Nidra is the on-demand relief. If you use it right, you know it. And you get that positive feedback. You get that, incentive. You get that really positive reinforcement that leads to that learning. I mentioned there's another 10% too. And even if they're using it properly, there are 10% who aren't getting relief. And we still don't fully understand it, but I do know one factor that explains it, and that is patients that are at the maximum intensity. They're titrated the maximum intensity the device can produce, and they just need more. So our research team is looking at, can in a future generation of product, can we deliver a higher intensity for that 5 or 10% of patients who do truly need more? And then there's some other factors that we're still trying to understand. Um, and we didn't figure it out from the Thrive study. I'd hoped with 300 patients, some factors would pop out. And we looked at 100 different clinical factors. We looked at their history of medication, the medications they're on now, their RLS symptoms, how they describe them. And we didn't see any significant differences there. So it really does seem that, unless there's some clear barrier that's going to prevent this patient from learning how to use it or from positioning it properly over the leg, they're probably appropriate. As long as they meet the label, they're probably appropriate to try Nidra. And then as a prescriber, you just need to follow up with them and see, are they using it properly? And two, is it working for them? Are they continuing to use it? So I'll share, kick it back over to Dr. Spector. I know you mentioned some things about myoclonus, but any other predictive factors you've seen?
The other one that I would add probably is location of symptoms. I do think it works better if it's a lower leg problem than a thigh problem. And some patients with restless legs, we know it's a misnomer where it's not even legs. I have patients with restless back and restless other things. And, so if their label is restless legs, but the predominant source or location of the restlessness is not in the territory of the peroneal nerve, a peroneal nerve stimulator may not be ideal for them. So I found that may be one of the most predictive things. The more classic their symptoms, I have creepy crawly feelings in my calves, which is stereotypical RLS. That is very predictive of success. So the ones I've had less success with were the ones who had less typical features. And so that's probably the one I would say I would add to what we've talked about before. And my experience with therapy support is outstanding. I mean, the patients rave about it. They say, all I have to do is call up and they help me, and they've been very responsive. So I can reassure the patients that they will have the support they need. As Jonathan said, they have a team of people who do this all day. So it's easy to get a hold of them, and from my end as a provider, I can email my rep or text my rep and get answers, within the day, very, very, 100% of the time. So it's been very easy to work with them.
Well, thank you so much for sharing your experience. And just to wrap things up, I wanted to share, as a representative of Noctrix Health, our ambitions and our aspirations and, where we are today, but also where we're seeking to go tomorrow. Today, as I mentioned, we're covered by Medicare. We're available at the VA Medical Center as well, and we're seeing rapidly improving commercial coverage for patients that are below the age of 65. As we're in a state longer, we see a higher likelihood of positive coverage policies. It took us a while. We provide a lot of therapy support. We provide titration support. So we didn't just like click a button like a drug does and be available nationwide. It took us a couple of years, but we're there now. We're available in 49 states. Still waiting a lot on a license in Alabama. But we realize there's a tremendous unmet need in Europe and overseas. And so that's what we're evaluating next. How do we go beyond the United States? Canada too, we hear about the unmet need there. The indication of refractory RLS, as we mentioned, it's a broad indication. It covers 2 million people. But there's an unmet need for non-drug treatment, low-risk treatment in medication-naive patients and first-line patients, and certainly an enormous unmet need in pregnancy, in pediatrics. So these are areas we need to evaluate for the future, and we're really excited to study those. Um, we're also looking to see, what's the full potential of this category of technology? If you were to stimulate at a higher intensity for a longer duration, can we do even better than what we're seeing here? So our research team is always studying new features, and maybe the next time I talk to everyone here with the Sleep Research Society Foundation, um, we might present on some of that new data from the new technology that might come out. We're grateful for the opportunity to serve more than 4,000 RLS patients already, but there are 2 million that need relief. So looking to the future, uh, we're excited to scale, we're excited to grow, and we're always listening to patient and prescriber feedback to see how we can do better. I want to thank the full team who collected these data, the investigators, the prescribers who helped evaluate these patients and collect these data that we saw today. Um, we don't have too many questions, but I did see if you do have any other questions, please send them in Q&A. We did have one question in two parts. The first part I'll cover, and then Dr. Spector, maybe the second one I can kick over to you. But the question was, does FDA mention which medication has to be refractory? And the FDA does not, but the clinical trial did. So when we're looking at who is covered by Medicare, the rule there is they need to have an inadequate response to either a dopamine agonist or a alpha-2 delta ligand. So that's pregabalin, gabapentin, gabapentin carbo, rotigotine, ropinirole, pramipexole. If it's one of those six, they're definitely considered refractory. And again, that can be at any point in the past or present. If they'd only gone on an opioid first line, which is extremely rare, they would not be considered refractory um, based on that Medicare definition. Um, you'd still send in the script, but we need to appeal that decision most likely if they were refractory to a different medication. Um, and then, Dr. Spector, I think the second question for you is, do you ever have patients fail opioids for RLS before moving to Nidra?
Um, no. And first of all, I wouldn't wait for them to fail opioids. And second of all, there are actually very few opioid failures. And so that would be a really small population. My philosophy on opioids is try them all, figure out which one the patient tolerates best and works best. And when you get to the right dose, they're almost always providing some relief. There aren't a ton of opioid failures. I can count on one hand the number of times that's true. So I definitely don't wait to fail opioids. What I do is I use them both so I can try to keep the opioid dose, which is already low, even lower, right? You're already only using small doses. So I consider them compatible and complementary.
Fantastic. Well, thank you all for your attendance today. I think we're at the end of our time, but please stay tuned for the publication of the data that I shared. The 90-day data from this study are currently in review. 1 year data will probably be out in about 9 months. And finally, on behalf of Noctrix Health, I'd like to thank the Sleep Research Society Foundation for the opportunity to share these research results with you today. and for everything they do to advance the field of sleep research. And the official recording of this webinar will be provided to all attendees and on the SRS Foundation website when it's available. Thank you very much for your attendance. Thank you, Dr. Spector, for joining us today. Thank you, Dr. Ching, for organizing. Take care.